All right. We've got a quick 11 studies to get through. I promise they will be quick. There's only a few things that we need to say about each because thankfully this time around they're actually almost all straightforward. So first up, eccentric exercise therapy for medial, so inside epicondylitis, basically elbow pain. So everybody knows, lateral epicondylitis, you've got tennis elbow, uh, other colloquial names between lateral and medial, just like golfers, tennis, a whole bunch of different names that are tied with it. All you need to know, it's elbow pain, and it's elbow pain on the inside. They like to say that it's less studied than the more common one, but I've seen both in my clinic. And what this study really says is what we already knew about its, you know, brother, the outside elbow pain, in that eccentric loading does seem to be a fantastic tool to reduce pain and improve grip strength if you have this condition. Because again, if you have inside elbow pain, you're not going to want to squeeze, you're not going to want to grab and do dexterous work. And it can be surprisingly disabling for the person with the right lifestyle. So if we incorporate eccentric loading or slow and controlled loading, also called negatives, um, long duration hold, etc. Actually, that's more isometric, but controlling the movement a bit more seems to help with the actual condition itself. Obviously, we have another blurb in here where it says, combined exercise-based approaches showed superiority over a passive intervention. So this one was ultrasound. So no matter what we want to do to help calm the symptoms, it should always be in conjunction with some sort of active approach, because we are not designed to lead just passive lives. We are designed to be active, and therefore almost any intervention that we need to include is going to be something active. That's not saying manual therapy and things that make you feel good are wrong. It's just they shouldn't ever be considered as a standalone treatment. All right. So that's what that one says about inside elbow pain. Same way that we basically treat outside elbow pain. Next one, we wanted to, this study, investigating the effects of, oh, look at this, eccentric stretching on pain, grip strength, and functional outcomes in patients with lateral epicondylopathy. Basically, same bloody thing. Even though it's a stretching at the right tension is still somewhat of a load going through the muscle tissue. We're doing it in an eccentric manner where we're controlling it. And so what do we know? We know the same thing that a lot of other studies have said, in that eccentric load seems to help these conditions. Okay. Some people might make the argument, concentric versus isometric versus eccentric in the end don't matter compared to load, but it's in the question itself of tolerable load, where sometimes it's the way that you do said load that matters the most, which is why people prefer eccentric. Put another way, rather than trying to rep things out and do different things smooth, fast, etc. Maybe a patient can't tolerate the speed because there's either a coordination issue or there's a fear avoidance issue, and telling them to perform the exercise in a more controlled manner, i.e. a slower manner, lets the patient process their experience in the context of, even if this is painful, it's not damaging, therefore I can do it, therefore I will get stronger, therefore I'll get better. So even if all things are the exact same between concentric, eccentric, isometric on paper, applying them to the patient's experience of the exercise may be where there's more merit in one approach over the other. I could say that for any individual approach. Maybe some patients holding it through a painful range of motion, like doing a 5-second negative, it's 3 seconds of just suck they can't handle yet. We won't do it. We'll do maybe an isometric just into or below the threshold of pain, so that they get to explore the movement again, but not actually having pain and building up some capacity. Or maybe, having them do concentric with only a mild level of discomfort is going to be a-okay to keep them as active as possible while this condition heals between, because time is going to be a huge factor for most of the conditions that you treat or experience. So if you're able to do things and stay as active as you can and give time a fair shot while you're being managed and overseen by a PT, chiro, MD, whomever, might be what's needed for you. So eccentric is still a huge player in the game. There may be arguably a few mechanistic reasons that I won't discuss, but even if we table those to the side, this whole little diatribe that I went on, even if all things were equal, not because of the potential mechanism reasons, the patient experience reason may be enough to warrant a patient going through this style of exercise because of what it does to change that person's experience through the movement. Okay. Now, we're ready to down. We're on to number 3. PRP, or platelet-rich plasma injections, do not improve pain or function in patients with lateral epicondylopathy as compared to placebo. So I've had a lot of patients ask me over the recent years about PRP injections. And this is one of those instances where it seems to be a combination of you need to have an optimum dose, which you don't always get depending upon the clinic, as well as, not the optimum dose for you. But these seem to be very regionally specific in where they are actually showing to be beneficial, if at all, in the studies. So I've seen more studies than not that are showing they are not effective. So like this one, if you're considering, like we discussed, hey, I've got elbow pain, should I get a PRP injection? This study is saying, no, we can't recommend it because there's not good evidence to say it's effective. There is a mixed bag when it comes to effectiveness in other parts of your body. So I've seen 1 or 2 that say yes for knee pain, but I've also seen 1 or 2 that say no. I've generally seen similar when it comes to shoulder. So this is going to be kind of like a lot of other emerging healthcare trends where either there are factors on the patient that it was done to that aren't controlled for, that actually led that patient to getting the benefit. So PRP was effective for that patient. There are pathologies that need to be studied to see if they are pathology specific. So, all right, so this type of pain that the patient is experiencing is vague. Is it just a acute, semi-acute, or subacute inflammatory condition? Is it an ischemic condition? Is it a degenerative condition, age-related condition, arthritic condition? Is it any one of those reasons that PRP may or may not be more effective? And that's something that, maybe after this call, I'll peruse some of the broader literature again, just to update myself so that I'm not always speaking from memory here. But as of right now, PRP is something that we want to be very cautious about. Because again, you will hear about the patient where it was the panacea, the cure-all, and you can't entirely discount the case studies that show the N of 1 benefit, as well as some potential anatomy specific and or condition specific benefit, but that's kind of where it stops. We need to study these more before there can be any legitimately solid recommendations, because this one came out, I believe, beginning of this year. So this is 2026, and they're studying it in elbow pain. And they're like, look, based on this one study that we did where it was a meta-analysis of randomized controlled trials for elbow pain, we can't recommend it for elbow pain. But we need to then repeat that ad nauseum for knee pain. We need to do it for shoulder pain. And we want to make sure that we do it right, because a lot of the people that are going to argue for PRP are going to say something along the lines of, when you went through and studied or references, when you went in and studied the references that the research is quoting from, a lot of the people that utilize PRP in their clinics are saying that they're not using an appropriate dose to get the benefits that are described out in public or with these individual case studies. So when they set up the randomized control study, they're not doing it, according to these practitioners, at a sufficient level to get the benefit that they're seeing. So it's a wash. So there's a lot of things that aren't answered yet, aren't addressed yet. And it's one of those things where I'm going to personally be somewhat agnostic on this approach, because I've had patients where they swear by it. I've also had 1 or 2 patients where it was just like a big waste of money for them. And then there's also the consideration of, side effects and risks when you go under any treatment whatsoever. So all things that have to be weighed out. I'm going to be neutral on this because you know what? If it works, great. We got another consideration to get somebody better over the short, medium, and long term. And if it doesn't work, all right, fine. There's so many other things that we can do, clearly, because we just discussed eccentric loading, which you should probably be doing anyway if you're going to even consider this injection. That is still something that is done to you, not something that you are doing to necessarily take action over the condition yourself, which has a huge role in your actual healing, prognosis, outcome, etc. So PRP injections aside, we still have enough evidence to say you should be doing some sort of eccentric controlled loading, exercise, movement, etc. And this is just going to be a cherry on top for the tough cases, if it works. Caveat: if it works. And this isn't something that somebody should necessarily seek out as a first or frontline thing, because again, whether it works or not, you still will need to do some sort of movement and exercise to get that long-term benefit. Now, moving on. Let's see. Oh, an MRI study. Title is Abnormalities on Spinal Magnetic Resonance Imaging, MRI, in Children and Adolescents. This is a looking back retrospective cohort study. This one really says, again, what most other MRI studies do. This one, again, just subspecified children and adolescents, because a lot of the times, if you're dealing with somebody in an age demographic that doesn't have a lot of robust data necessarily, and actually that might be a bad way of saying it. A lot of different things present in children and adolescents a different way than they will in an adult. Combine that with the fact that children and adolescents aren't always the best at giving testimony to what they're going through, recalling symptoms, timelines, timeframes, as well as explainers of various things and symptoms that they may or may not recognize that they are going through, will oftentimes make managing conditions, specifically like MSK conditions, particularly difficult. And so when you're dealing with an adolescent or a kid, I have the luxury of time if and or when I choose to see somebody younger. And a lot of the times, even then, it is still very difficult to always get an accurate direction the first go, because of what the person is either explaining to you, that they're confused about, and that they're trying to relay to you. And you're always having that thought in the back of your mind that there are certain big bad conditions that you don't want to miss as a practitioner, especially in somebody so young, because we don't typically associate the young with having some of the similar pain experiences that older patients do. And so it can be unnerving, let alone if you're in an environment that has 5-minute appointments and you're just going through and being like, I don't know what this is. Let's just send the kid out for an MRI so that we get those answers of the big bad stuff out. So that's just a little bit of a background on what this study, or why the study may have been considered, why it was done, and a little bit of background and context so that when we discuss the results, it kind of makes sense in context. So this one is at least reassuring in the sense that MRI seems to have a similar result and now similar guideline recommendations to the adults. And it's a small win because the history taking, the medical experience dealing with these kids and adolescents are still sometimes vague enough where you don't necessarily want to fault somebody getting an MRI. But as far as the results go, it is that if you don't have a legitimate clinical reason for the MRI to begin with, and you are sending somebody first to an MRI for vague low back pain, you're going to get the same crapshoot results that you would get with an adult. In that, and let's see if I can find, here we are. So in this population specifically, and then I'll talk about it, the adults, because I'm a little bit more up to speed on them. So main findings of this study are only 19% of spinal MRIs in children and adolescents revealed any clinically relevant abnormalities related to the symptoms presented in clinic. So 1 in 5 for something that cash rate, you're still looking at like $700 on the cheap end. Insurance network rate, you're spending several $1,000s for, and you have a 1 in 5 shot of actually catching anything that's relevant to somebody going through back pain. It's not nothing, but again, 1 in 5. You can narrow that down to better odds by going through either a better history or potentially a trial of care first, ideally conservative, and then figuring out if it is a difficult to manage case, if more symptoms come out, etc., that may lead you into actually having additional evidence to send them out for an MRI. Let's see. Things that stood out that actually they caught. So again, these are things that you want to, if you want the MRI to have the results that you're looking for because the MRI will catch something, these are some things that stand out as far as symptoms go that would warrant going up the chain to get an MRI. So patients with neurological abnormalities, that should be a no-brainer. If you have back pain and then you have some sort of neurological deficit, like I can't pick up my foot, I have foot drop, I have saddle paresthesia, I have, pick a phrase that it screams neurological abnormality. If you have this one was interesting, a shorter symptom duration. So that's one of those, again, like it comes on fast is how I'm reading it. So it's not like, oh, it built up very, very slow. We can track it. We can trend it. It's nothing major. Maybe it's because then it's maybe something, lifestyle related versus now this came on like 4 days ago after they did a triple quadruple backhand, yada, yada, yada in gymnastics. So, and it's really bitey, and they're starting to have a little bit of numbness and tingling and weakness in their legs. It's like, okay, came on quick, short duration. We had that neurological abnormality. Another thing that stood out for them was specific clinical indications other than chronic back pain were significantly more likely to actually have MRI findings that provided added diagnostic value. So this is going to be things like trauma. This is going to be things like history of cancer, genetic predispositions, certain medications, things that start to kind of tell you, okay, I'm seeing more and more smoke in this area, so I'm presuming there's a fire, if that makes sense. So now with the adults, it's very, very similar because if you just blanket MRI 100 people over the age of 50, a majority of them are going to have rotator cuff tears, and they may not know it. Ergo, they don't have symptoms, which means, is it of any diagnostic value if you find it? No. All right. Not all of us are textbook normal. I think, this was still like 10 years ago. 10 years ago, they were saying up to 50% of people have some sort of anatomical variant off of like your textbook. Like if I go here, anatomy textbook, half the people do not have all of the perfect anatomies in there. There's anatomical variants of, exactly where does a nerve flow through? Does it go above a muscle, below a muscle, through a muscle, an actual additional muscle or lack thereof? You get the picture. So if you just happen to MRI 100 older people, older, 50 and above, they will, a majority of them will have a rotator cuff tear, some sort of degenerative disc disease and or degenerative joint disease, labral pathologies, either in the hip or shoulder, you name it. The whole point is they have these things without the symptoms because the actual lesion, the tear doesn't matter to that person's capabilities or pain experience. So what does the MRI tell you? Nothing in that case. You just happen to find a non-important pathology, lesion, tear, etc. Same thing is really being said about kids. there's just added, in my personal opinion, mud to the waters because of sometimes the, we'll call it obtuse nature of treating those kids. Like, more power to pediatricians. Love you guys. Couldn't do your job. Not even just from a scope, that just patient population scope notwithstanding. All right, this one's short. The presence of temporomandibular disorder is associated with an elevated risk of obstructive sleep apnea. This is just one of those things, again, where you see one, you see another. These things are related as far as, does one cause the other? Not necessarily, but just because it's not a direct cause, obviously doesn't mean that there's not a correlation. So whether or not you care to actually go into the research and figure out what is the exact mechanism of why this happens, right now, not important. What is important is, let me see if I can find, I think they said the actual amount that you have a greater increased risk of it. I can't really find it right now. Anyway, it's enough where it's relevant. So if you see or smell one, look for the other. So in personal experience, oftentimes you'll hear first the jaw symptoms, like the patient feels them, they're awake with them, etc. They're not always aware of some of the background symptoms that they're experiencing that would be an actual sign of sleep apnea. So in all likelihood, if you hear somebody having jaw pain, and it's not able to be going away on its own, or it stays there for a fair bit of time, do expect that they may want to actually have a sleep specialist evaluate them for sleep apnea, because you don't want somebody who is developing or has developed TMD to then actually develop sleep apnea, because sleep apnea will, in general, outside of the symptoms you experience, hinder the recovery. Not necessarily stop it, but it will slow down and will play a significant role in the recovery if it's not addressed, if you're trying to treat the TMD. Next up, effectiveness of soft tissue manual therapy in managing chronic plantar fasciitis. Put another way, chronic footbed pain near the heel. Systematic review. This is, again, in conjunction with the standard of care, so exercise, lifestyle stuff, like all of that good stuff. One group just happened to get the addition of soft tissue therapy. What they found was adding it in seemed to add benefit for people going through this condition, ergo it was better than control. They did note, however, and I respect them for this, that so far at this stage, they can't necessarily recommend any one actual manual therapy over the other, because it doesn't seem like it really matters. It's just the fact that somebody is going through some sort of manual therapy. And I think they call out instrument assisted work. Other words, it's also called scraping, as well as, what was the other one? Myofascial release therapy. They were associated with consistent improvements in foot function and pain relief. However, the design and comparative strategies, yada, yada, yada. So again, is it the thing that will cure you? No. It's in conjunction with standard therapy. Again, manual therapy, good or bad? Really, it's just depending on the lens and context. If it is the only thing you are ever looking to get, you don't take action into your own health, and or your practitioner only recommends manual therapy, at best, it's only good in the short term. It's actually not doing that much for you. And at worst, it's basically going to make the condition worse for reasons that I don't have time to get into, other than you will essentially circle a feedback loop of, I hurt, I go see so-and-so to get manual therapy, I feel a little bit better, but then I hurt, you cycle, chronic pain sets in, and other downstream effects happen that actually makes you worse than if you actually took care of it in the first place. Is manual therapy the best thing ever? Also no, but I'll phrase it as, if I was going through a condition, and I've gone through several, back pain galore, muscle tears, etc., I seek them out because I know what they do and how they play a role in my recovery journey. I know that they are the cherry on top of a sundae. They are things that make me feel better, and they help me do the active stuff better. That's how they should be viewed. If somebody can't do the active stuff well, and manual therapy can help them get there, do it. That is manual therapy's biggest and best role. In fact, it's why I love personally doing it, not just on the table. One thing that I absolutely love to do, and I was able to do this a couple weeks ago for a strongman event, was when the person hurts. So, like, we'll take this short example. This individual was having a bout of shoulder pain doing an overhead log press. So, what did I do? He couldn't make it hurt on the table. It was only when he loaded the thing. We went to him, had him do it. We used the scraper, instrument assisted work, while he was doing the overhead log press. And to him, it was magic. Like, wow, my shoulder pain's gone. To me, it was just, we bought him a window where his brain had to deal with an extra stimulus. He got new blood flow to the area. And at least for a short period of time, that brain figuring things out is happy. Okay. It doesn't have to necessarily put on the brakes. He could perform at the event much better. And this buys us the window to what? Do the active stuff better. That's my favorite thing to really do when it comes to manual therapy, because it is immediately tied and integrated with the active part of care. Enough said. We're on the back end of the research, so let's keep going. Deterioration in clinical outcomes in patients with lumbar spinal stenosis with a 12-year follow-up surgery survey. This one, this is one where it's, I don't want to say it's doom and gloom, but in my personal experience, actually, no, let me rephrase it this way. I think what I want us to take out of this study is two things. One, there may be certain conditions, and whether this is one or not remains up for, wow, I look like Dumbo if I do that. We're going back down with that. Some conditions, whether or not you go through an intervention, such as surgery, a pharmacologic intervention, conservative intervention, etc., some are not curable. Again, I don't know these individuals with stenosis. I don't know their time frames. There's a lot that I don't know about them. This just gives me a window to talk about this. Some conditions you need to view through the lens of management, not cure. Okay? And probably more than you expect. What I think is one factor on why 12 years out, these people were worse for wear compared to norm, and people that had to go through revision surgery, even worse than that, is because they were left through a one and done. Yeah, there was a couple of, if symptoms came back up again, they may have followed back with their practitioner, and that's where they got the revision surgery. However, if you just presume that the surgery and oftentimes too short a stint of physical therapy is what you needed to do to cure yourself or rid yourself of the condition, we're not looking at the big picture. The big picture should be, you need to view a lot of what you go through in life through the lens of, the end goal, the finish line is, us 6 feet in the dirt. So it's not, hey, I'm going to go through the surgery and I'm going to do 9 months of PT, and then I don't have to think about anything for my health ever again when it comes to this back pain and these symptoms. Nope. It's like, all right, you've got 9 months of focused work under direct supervision, but now I should take this and keep going, do exercises, do better lifestyle choices if they were a factor into any condition that we're talking about, not necessarily stenosis, and other conditions that may need more oversight and management, like autoimmune conditions. You shouldn't just go, all right, I saw my surgeon and I'm going to go this 10, 15 years before I really have anybody take a look into where I am at now, 10 to 15 years later. Maybe if you have more consistent oversight, somebody can track a pattern faster, we can do an intervention sooner, and we can steer a more positive course because we took this time to manage the condition, not just presume it's a one and done, not just leave us to our own devices. I hope you get where I'm kind of going with this, because I feel like if I just keep talking, I'm going to take 20 minutes saying the same bloody thing. With this one, it doesn't really say outside that they surveyed these people at semi-consistent time durations. So it was every year for the first 3 years, but then there was like an almost 10-year break. What were these people doing? Did they resume a lifestyle that would be protective of them developing these future symptoms or the stenosis? If they did, is there something about the stenosis surgery that leads to a higher risk or incident or, worse off disability into the future? Like, all of these questions need to be addressed. They aren't satisfactory here in this one. All this one really says is that these people were generally worse off for the ones who actually answered the survey, and the ones that had a revision surgery within the surveyed group were even worse off than the people that didn't have the revision surgery. So it's like everybody's worse than compared to their age match norm, and then the group that had the additional surgery is worse than them. I want us to go through and view this as, all right, you're going to go through stenosis surgery because you know what? You're somebody who needs it. This isn't doom and gloom, because why don't you just take your life by the reins rather than waiting 5 years and following up with your primary after the PT? Be more consistent with oversight, be more active in your lifestyle, and let's see if we can stack the deck in your favor and avoid all things. And God forbid we couldn't, because there's genetic factors that we just can't address, and you will need it for whatever reason on God's green earth. You will be more prepared to handle that revision surgery. That's something that isn't talked about when we're comparing pre and post-surgical outcomes with the context of exercise. Being more robust, having more and better quality tissue going into a surgery yields protective results for post-surgical outcomes. So even if you think of, I just need a hip replacement, doc says he's going to do it in 16 months, so I'm just going to, chill out. Wrong. You have 16 months to make that tissue around that bad hip as robust as possible to make your actual healing after that intense surgery that much easier, better, and you'll have a better prognosis because you put in the effort now. Do it. Last few studies. Spondylolysis and spondylolisthesis is associated with disc degeneration in pediatric patients. So again, this is something that is not uncommon and is more common in impact sports, especially impact sports that lead to extension. Idiopathic spondylolisthesis is one of the most common conditions that you're going to see in this subcategory. Basically, you have, let's see if I can get it in frame here. You have the spine link and logging together, and one is slid forward with respect to the one above it or the one below it. This is often due because where they link and log, rather than being tight knit, you have a fracture of some variety, typically a hairline fracture or a non-union fracture, where as the bone grows together to fuse as we go into adulthood, the repetitive stress just keeps that area from fully forming. It's not something that you should really take into consideration to hold your kids from active sports. You can't do that. Because life is messy. You can't protect kids from everything. So if you're thinking, well, geez, it's like, no, all it is a factor of, if a kid has a symptom, you just add this, checkbox to your list of possible reasons that a kid is experiencing, for, in this instance, low back pain. That's all it really is. Management varies from pure conservative care to conservative care with bracing, and only in the extreme instances do you ever really need to consider some sort of surgical intervention, because these are relatively self-contained. That's pretty much it. What we need to talk here is, often if you find it, you will hear something like, hey, you have this condition, and look at that, you also have degenerative disc disease. Oh my goodness. Or, disc degeneration. Oh my word, in a 16-year-old, that's unheard of. No, look, if the spine is going through an anatomical shift, it makes sense that when we're looking at something, we see that disc space narrow, which again, if one vertebra is sliding on the other, it may be stretched thin. They're going to call it degenerative disc disease or disc degeneration. Again, one caveat that I'll talk about in just a little bit, that's not something that you should really think is big and scary, like oh my gosh, they have old man back at the age of, no. It mechanically makes sense. The spine shifted. It's not bad necessarily. It's not dangerous necessarily. The disc will have to figure out what to do and where to go. And on an MRI, that will look like disc degeneration. Now, there will be oftentimes other inflammatory factors that they're also going to use, saying, or some sort of, there's a lot of verbs that I frankly don't want to try and remember off the top of my head because it's been too long with radiology class and I'll look like a fool. But there's other reasons that you would call things on an MRI, but it's not big and scary. It's something that I'm somewhat passionate about because I get MRI reports from some of these active athletes, especially their parents are like, hey, look, he has this big word that I don't know. The doc explained it this way. And he's already got degenerative disc disease. It's just like, yeah, he would, especially if it's a higher grade or a larger shift. That disc will naturally start to displace. It will look like disc degeneration. It's not scary. It makes sense for the condition he's going through. Don't panic about it. Now, there are some studies out there that show from like motor vehicle accidents that early conditions like this, early signs of degeneration lead to worse like osteoarthritic and or disc degeneration in the future. I'm not discounting that. That may be something that I'll bring up as an education piece for the parents, but I also then will back it up saying, yes, it may be worse, but it's typically worse on MRI. That doesn't mean it's going to be felt worse. So, in 40 years, compared to another, at this point, mid 50-year-old, the standard 50-year-old may have mild to moderate disc degeneration. This kid may be at a bigger risk of having severe disc degeneration. Again, everything must be taken in the context of what is the patient experiencing as symptoms. That's it. Okay. That's all there is to it. In review for this one, we've got 2.5 studies left. Spondylolysis and spondylolisthesis. Let's just keep it simple. Disc or spine shifting. Spine shifting can also mean disc shifting. Those things together can show on MRI disc degeneration. Not a death sentence, not really a fantastic reason to keep a kid from sports and athletics. Outside of the 50-year in the future conversation, not usually a reason or impactful thing that will alter any course of care for the kid in the immediate future. Like, all right, kids now got moderate disc degeneration at 16. Does that change anything that's going to happen? No, it does not. So if and or when it shows up on MRI, and it seems to be the more or worse or further slipped it is, the higher likelihood that it will show up as disc degeneration. It's nothing to panic about. Again, even if it's associated with worse degeneration in the future, it must be taken in the context of what you experience, not what is just going to be shown on the MRI. All right, last few. I'm going to save this one for last. Let's go to this quick one. Higher grip strength is associated with reduced risk of symptomatic hand osteoarthritis. So basically, if two people have the same imaging confirmation of osteoarthritis at the same stage, like it's the same level of bad, the person that's either has or will develop a higher grip strength will have better functional scores, outcomes, and reduced pain. I don't need to say much more than that. It's self-explanatory in the title. I love these ones. Next up, unhealthy lifestyles and low scores for things like, we'll get into them because that's actually the point of the study. So let me rephrase. Unhealthy lifestyles that are associated with a higher risk of new onset low back pain, a cohort study. So not all inclusive, but it hits a couple that are at least worth talking about. So let's see. The factors that stood out to them that had you have an increased risk of developing new onset low back pain, prolonged sedentary time, elevated BMI, unhealthy sleep patterns, abnormal sleep duration, current or former smoking, insufficient physical activity, and poor glycemic status, ergo poor blood sugar control. And I guess current and former smoker Those are 2, so there equals your 8. So if you want to reduce your risk of developing new onset low back pain, you will not sit down for too long, make sure that you're at a healthy BMI for you, have a healthy sleep pattern, have a healthy sleep duration, make sure that you never smoked, or if you did, cease, because even if former smoker is a risk, it's lower than current or chronic. Make sure you get enough physical activity and make sure you're able to manage your blood sugar accordingly. Last one. The effects of short-term dietary calorie restriction combined with aerobic exercise on systemic inflammation in overweight or obese individuals with knee osteoarthritis, a randomized controlled trial. Now, again, I've harped a long time about it's not just the actual physical weight that plays a factor in somebody having symptoms or reasons why we need to reduce weight when it comes to taking care of a lot of these MSK conditions. It's not just the mechanical weight. There's a lot of chemical factors. This took a look in a very short window in that, or looking at knee osteoarthritis through that exact lens. So the highlights from this study, let's go, let me scroll, here's the highlights, 3 highlights. 4 weeks, so really, really short, like ridiculously short. That's the one thing I don't like about this. 4 weeks of diet plus cycling reduced a chemical marker, interleukin-6 or IL-6, but not CRP, which is something that is also highly sensitive to inflammation, compared to diet alone. So 4 weeks of diet plus cycling reduced IL-6 compared to diet alone. The combined intervention of diet plus cycling led to a greater reduction in knee pain. The combined intervention also led to a greater improvement in another test that they did to figure out how well this person is dealing with knee osteoarthritis, the stair climb test. So again, very short window, but even then, there was enough benefit to highlight that diet didn't do nothing. It did something to reduce knee pain. Diet plus exercise really help these individuals with knee pain. And that's something that is worth highlighting. It's worth putting out onto the web here. So if you're dealing with knee pain, like several people that I know, several patients and several family members, this is a standard of care for a reason, for different mechanisms. So the diet's doing something, the calorie restriction is doing something chemically and physiologically in your body that is going to help improve the knee osteoarthritis and the pain experience. The exercise, through a different mechanistic reason, is going to improve knee pain and knee osteoarthritis symptoms. So put them together, it's like that ratatouille. You know, take one flavor, you take another, you combine them, and you get this whole new world. Same idea. You just got to find the right approach. You got to find what is tolerable, and you can't stop. Be consistent and do this with an appropriate level of intent and intensity. Because I think that's the biggest thing where people dip off. For example, before I end this here, the calorie restriction, over the course of the entire week, they asked these people to reduce their calorie intake by 5,000 calories. That's something like, what, just over 800 calories a day, which I've done calorie cuts like that. Yeah, you feel them. It's not impossible, and you can stick with it for a fair bit of time. And there's lots of different techniques, tools to stay somewhat consistent with calorie deficits, lifestyle choices. There's different things you can do to take these things like in a stepwise fashion, where you can go through a period of cutting. You can then go on a period of maintenance, or even a little bit of a reverse diet to reestablish eating patterns, hunger, and then go through a cut. So it doesn't have to be a linear, like, oh, I got to cut 800 calories out and just keep it at baseline here. No, there's a lot of people that will benefit from cut, reestablish, maybe even relax a little bit, cut. And you should look at this from a longer view window. This isn't the whole, well, it's spring and I want my summer body, so I'm going to do, 10 weeks of hard super cut. Can people do it? Yeah, it's not always the most healthy. And when we're talking about health, macro lens, long picture, what can I do over the next 6 months, year, 2 years, and 4 years? And when you look at a time frame like that, having a 3, 6, even a 10-week window where you boost your calories back up, but I'm going to gain back 5 pounds. Like, yeah, if we do this right, you're going to lose another 8 or 9 in the next cut. But then I'm going to gain back 6. Yeah, you know what's going to happen? We're going to cut them down again, and you're going to net lose because we're looking at this over an appropriate time period. Same thing with exercise. Oh, I couldn't fit it in today, or I didn't want to. It was only going to be 10 minutes. You know what? I only have 2 days. Like, wrong mindset. Okay. Wrong mindset. Something is better than nothing. Consistency is key. Doing it at an intense enough level is key. Okay. And that last part is, I think, what I want to end on is that don't be the people that I also see in the gym that say you exercise for 2 hours a day because you hear me say these studies. Oh, if I exercise, I'm going to be better. I'm going to be this. You go into a gym, you're there for 2 hours, but realistically, you spent so much time being distracted by, you have to set things up. You got to post to Instagram. You got to answer so many calls. You're going to take it easy. You're going to do a, 25-minute warm up, all of these things before you get into the actual work of it. Yeah, you were at the gym for 2 hours, but you had maybe 25 minutes of actual exercise time. So that is something that is oftentimes a harsh reality that we have to discuss with patients that, but I meet all the guidelines. I did my 300 minutes a week of this. I did my 2 resistance training days. I believe you, but the studies also show there's an intensity level that has to be met to get the benefits we're discussing. Okay. So if any of these things, the diet, the exercise, the management of the condition, the education, if you have issues with any of it, you're still experiencing symptoms, please reach out. I love to help people like you. I love to take the time and actually work through things like this with you in a one-on-one setting to make it personable and impactful. Okay. So if you're somebody's like, but I'm doing all the right dieting, I'm doing all the right exercising, and I still have, talk to me. Maybe you are, and we have to add something else, but there's also a fair chance you may be thinking that, but there needs to be an accountability partner and somebody who has the ability to look at what you're going through objectively to highlight where we think we're doing something, but we're actually not. That's a big part of like the nutrition side. I'm only eating 1,200 calories for 3 days, and then you have 2 days of 4,000. So as a week stands, you're still in a net calorie surplus. Like, you can see this is definitely something that I can squirrel down different rabbit holes quite a bit. So I will leave it at that call to action. If any of this sounds like you, please reach out. I have fun with this. And until next time, have a great weekend.